Hi class and welcome to chapter 25. This chapter will be on the respiratory system and we'll go over some of the anatomy that I'm hoping you're studying in lab right now or you will be soon. So as we look at the respiratory system, we'll look at how air passes through it and we'll look at the way air goes through all of the respiratory structures. We divide the respiratory tract into the upper respiratory tract and the lower respiratory tract. And you can see the structures involved in the upper respiratory tract and how air will be conducted through the nasal cavity down through the pharynx. And then the lower respiratory tract consists of your larynx, the trachea, which will split into bronchi on each side of the lungs. And then the pleura is just the word for the lungs, and the diaphragm will be the muscle that the lungs sit on top of. So again, the respiratory tract, we divide it into the upper and lower respiratory tracts. These are the structures in the upper portion, and these are the structures in the lower portion. And we will go over each of these structures in detail as we go over the next couple slides. So the route of air will enter your respiratory system through either the nose or your mouth, and air will entering the nose will pass through the nasal cavity. Within the nasal cavity, you have a lot of arteries, veins, and capillaries, which will bring nutrients and water to its cells. So this is where your air will be humidified and warmed up in the nasal cavity. Your nasal cavity is the passageway that will filter out dust, dirt, smoke, bacteria, and other contaminants. The first filtering of your air that you breathe in is done in the nasal cavity, and the nose in the nasal cavity will do three things to the air you breathe in. It'll filter the air, it will warm the air, and it'll also moisten the air. So here's a look at some of the histology of the nasal cavity and the lining of the respiratory tract in general. This is pseudostratified ciliated columnar, and these asterisks are in goblet cells, which will secrete the mucus, which will trap any harmful substances that get into your respiratory tract. And the cilia will move the mucus along the respiratory tract. The combination of the cilia and the mucus will help to filter out any solid particles from the air, and the warm and moist air will help prevent damage to the delicate tissues of your respiratory system itself. And this also helps to keep the air entering the nose from drying out the lungs. So you want to keep the air moist and warm. When air enters through the mouth, much less filtering is done. So it's much better to always try to breathe through your nose. So here's a look at the nasal cavity in the nose. The nasal septum divides the nasal cavity into right and left halves. And then you have these concha, which will form the lateral wall of each cavity, and they will help condition the air within the nasal cavity. So they'll help warm it, create some turbulency to the air, and moisten the air. The paranasal sinuses, these are paired air spaces that make the bones lighter in weight. So these sinuses are named for the bone that they reside in. So you have your frontal sinuses residing in the frontal bone. So their spaces kind of in between the eyebrows. The ethmoidal bone will be spaces in the ethmoid bone, right between the eyes or on top of the nose. The sphenoidal sinuses and the maxillary sinuses are just spaces or cavities within those skeletal bones. The pharynx then is just another word for throat. So as air pushes back from the nasal cavity, it enters your throat or your pharynx. The pharynx is located in the back of your mouth and serves as a passageway for both food and air. When your food is swallowed, a flap of cartilage called your epiglottis will press down and cover the opening to the air passage, which is your larynx. So if you ever are coughing or if you say something got down the wrong pipe, that's because your epiglottis didn't close quickly enough and a little bit of fluid or food got to the opening of the larynx. So here's a look at the pharynx. Again, it's the region that's shared by the respiratory and digestive tracts. So it's your throat. The nasopharynx is the pharynx behind the nasal cavity. The oropharynx is the throat behind the oral cavity. And then the laryngopharynx is the throat or area behind the larynx or your voice box. The nasopharynx is continuous with the nasal cavity, and superior to the soft palate. It's lined with that same pseudostratified ciliated columnar epithelium that we see kind of throughout your respiratory tract. The opening of your auditory tubes is found in its lateral walls, and those auditory tubes, if you remember, will open up to the middle ear, that air-filled space where your ossicles are. And then the posterior nasal pharynx wall will house a single pharyngeal tonsil, and those are the adenoids. The oropharynx begins at the end of the soft palate, and you can see the soft palate here where my cursor is, and ends at the level of your hyoid bone. When you swallow, the soft palate will elevate to help prevent things or food or drink go up into the nasal cavity. The oropharynx is lined with non-keratinized stratified squamous. So it's several layers thick of those squamous alive cells to help with abrasion of food that's going past it. The palatine tonsils are embedded in the lateral wall between the arches, and the lingual tonsils will be at the base of the tongue. The laryngopharynx then starts right inferior to your hyoid bone and is continuous with the larynx and the esophagus. It's lined also with non-keratinized stratified squamous epithelium to try to resist the abrasion of the food that's swallowing or sliding past it. So here's your larynx. It's also known as your voice box. So from the pharynx, air will travel and move in through the larynx, the upper end of the trachea, and then into the trachea. This will then lead directly into the lungs. Inside your larynx, stretched across it, are two highly elastic folds of tissue or ligaments called your vocal cords. And when air rushes through your voice box of your larynx, that'll cause your vocal cords to vibrate, and that'll produce sound waves that you need to speak. The larynx connects your pharynx to your trachea, and a couple other functions of your larynx, besides being a passageway for air, is that it also prevents ingested material from entering the respiratory tract, and that's because the epiglottis is at the top of it. It produces sound for speech with the vocal cords. It assists in increasing pressure in your abdominal cavity, and it also will participate in both a sneeze and a cough reflex. So here's a look at your larynx anatomy. Here's the epiglottis, and we'll look through the larynx to see the vocal cords in a second. The V-shaped prominence, also known as the laryngeal prominence, or the Adam's apple, is much more prominent in males than in females due to testosterone-induced growth. So during puberty, testosterone will make this laryngeal prominence kind of jut out larger. So the next time you're out in public or with your family, you can notice there's a definite larger Adam's apple in males than females. Testosterone will also affect the vocal cords of your larynx. So testosterone will make the vocal cords longer, and the longer the vocal cords, the deeper the voice. So that is what deepens teenage boys' voices during puberty. Your larynx is supported by a framework of 9 cartilages held in place by ligaments and muscles, and you can see some of those there as well. The following paired cartilages play an important role in the sound production: the arytenoid cartilages, the corniculate cartilages, and the cuneiform cartilages. Here's a look at the vocal cords as seen from a laryngoscopic view, so a camera that's been kind of sent down, and you can see the vocal cords and how the cartilages and ligaments surround them, and how they can open and close to produce the sound vibrations or sound waves. Vocal production, so speech is the intermittent release of expired air while opening and closing the glottis. Pitch is determined by the length and tension of those vocal cords, and loudness depends upon the force at which the air rushes across the vocal cords. The pharynx resonates, amplifies, and enhances the sound quality, and the sound is shaped into language by action of your pharynx, the tongue, the soft palate, and lips. So a lot goes into speaking. If you're interested more in that, you should look into becoming a speech pathologist. It's a great career path. I think they make pretty good money too. But a lot goes into speech, and a lot goes into helping kids kids speak if there's a problem detected early on. So from the larynx, the warmed, filtered, and moistened air will pass downward into the thoracic cavity through your trachea. And the walls of the trachea are made up of rings of tough, flexible cartilage. And these rings of cartilage help to protect the trachea, make it flexible, and keep it from collapsing or over expanding. And from the trachea will branch into bronchi and eventually smaller and smaller bronchioles. So here's a look at the cells lining the trachea. They'll produce mucus, and this mucus will help to capture things still in the air and will be swept out of the air passageway by tiny cilia into your digestive system. The mucosa is lined with a pseudostratified columnar epithelium with those mucin-secreting goblet cells, and smokers have trouble because smoking will completely change this epithelial lining of the respiratory tract. It'll completely kind of abolish the mucus secreting cells, the cilia. So smokers' lungs will become more dark and blackened, not just from the smoke they breathe, but because they have no way of trapping any of the harmful particles anymore that they're just breathing in normally. So please stop smoking. And I'll get off my soapbox for that. If we were in class together, I'd probably talk more about the dangers of smoking, but we'll maybe come back to that in the digestive system. So here we look at the bronchi. So your trachea will split into bronchi. And you'll notice here that the different sides of the lung have different, within the thoracic cavity, the trachea will divide into two major branches called bronchi. There will be a left and a right bronchus, and then each bronchus will enter the lung on its respective side. And you'll notice that the right lung has 3 lobes and is slightly larger than the 2 lobes on the left lung. So the bronchi will go to each lobe of the lung. And that's because on the left side of the thoracic cavity, you'll have a space for your heart. So the left lung will just have an upper and a lower lobe. The lungs are encased in the pleura membranes that secrete a mucus that will decrease friction from the movement of the lungs during breathing. So here's the bronchial tree splitting into right and left main or primary bronchi, and it will continue to split and lead into progressively smaller tubes. Each main bronchus will divide into lobar bronchi, and lobar bronchi will divide into segmental bronchi. As branching continues, there's a couple things that happen. Incomplete rings of cartilage become smaller and less numerous. All the bronchi will be continued to be lined with that pseudostratified columnar epithelium. Bronchi will branch into bronchioles, which eventually will lack rings of cartilage and will be lined with just simple columnar or simple cuboidal epithelium. So here's a look at the bronchi branch and how it branches into smaller tubes that eventually are less than 1 millimeter in diameter. These are called bronchioles. Bronchial walls do not contain cartilage, but they do contain a layer of thick, smooth muscle, which will help the bronchioles to constrict or dilate depending on sympathetic or parasympathetic stimulation to the bronchioles. So during sympathetic stimulation, your fight or flight response, you're going to want your bronchioles to dilate to get more air, more oxygen into your blood. And during parasympathetic stimulation, your bronchioles will constrict because you do not need as much oxygen getting into the bloodstream. And then the final segment of conducting pathway will consist of the terminal bronchioles. The terminal bronchioles will branch into respiratory bronchioles, and respiratory bronchioles will branch into alveolar ducts. Alveolar ducts will end with a dilated alveolar sac. And then all of these respiratory portion structures will contain small saccular outpockings called alveoli. The thin wall of alveoli is where gases, oxygen and carbon dioxide, will diffuse between the blood and the air in the lungs. So this will be the site where oxygen diffuses out of the air into the bloodstream, and where carbon dioxide will diffuse out of the blood back into the lungs to be exhaled as waste. So here's an alveoli. The bronchioles continue to branch out until they finally end in clusters of tiny hollow air sacs called alveoli, groups of alveoli look like little bunches of grapes. There are approximately 300 million alveoli in your lungs, and all exchange of gases, carbon dioxide and oxygen, occurs in the alveoli. There's different types of alveolar cells. The type 1 cells are the simple squamous cells that promote the rapid diffusion of gases. The type 2 cells are more cuboidal in shape, and they'll produce the surfactant, which decreases surface tension within the alveolus and prevents the collapse of the alveoli. So in fetal distress syndrome, in babies who are born prematurely, their alveolar type 2 cells are not fully functional in producing enough surfactant. So fetal distress syndrome, if babies die because their lungs aren't able to, or the alveoli in their lungs collapse on themselves, so they aren't able to bring in the air and the oxygen that the baby needs. But in that situation, in premature infants, they're given some sort of other type of surfactant to help their alveoli from collapsing. Alveolar macrophages, or dust cells, may be fixed or free and engulf microorganisms and particulates in the alveolus. The alveoli consist of a thin, flexible membrane that will be covered in capillaries. The membranes separate a gas from a liquid, and the gas is the air that we take in through our respiratory system, and the liquid will be the blood. And you can see here, these are branches of the pulmonary arteries coming into the alveoli, and the pulmonary veins taking the oxygenated blood back. So gas exchange, you can see here from the capillary. The capillaries will come in and surround the alveoli, those little clusters of grapes, and the partial pressures will be different, so that oxygen will go down its partial pressure gradient and just diffuse by simple diffusion into the blood, and carbon dioxide will diffuse out of the blood because there will be a greater difference or less of the oxygen and carbon dioxide in the opposite way. So again, the air you breathe in, the oxygen in the air will diffuse into the bloodstream, and carbon dioxide will diffuse back out into the alveoli. And that's what you breathe out. You're breathing out carbon dioxide. Here's more kind of a detailed look at how oxygen jumps onto hemoglobin in the alveoli. Oxygen will jump off the hemoglobin in the capillaries of the tissues, and then the blood goes back to the lungs to get more oxygen. So oxygen here diffuses into the blood capillaries. It jumps onto the hemoglobin molecules, so we get oxyhemoglobin. And then when it gets to the tissue cells, oxygen will jump off of the hemoglobin into your tissue cells, and that blood will return back to the lungs just to get more oxygen. Here's another look at gas exchange. Again, a little bit talking about hemoglobin. Hemoglobin plays a very important role in the carrying of oxygen. It's found in red blood cells and has 4 sites where oxygen can bind to it. There are about 280 million hemoglobin molecules per red blood cell. So each red blood cell can carry over 1 billion molecules of oxygen. About 98% of all oxygen in the body is carried by hemoglobin, and hemoglobin will release its oxygen in areas where the blood concentration of carbon dioxide increases. Carbon dioxide is dropped off into alveoli from the blood, and you can see that here, how carbon dioxide will be dropped off into the alveoli from the blood, and then you'll breathe out that carbon dioxide as you exhale. Lung anatomy. So again, this is just a reminder, the surface area of the lungs, including the alveoli, is equal to about the size of a tennis court, which is really incredible to think about, but spend a lot of time, especially in this section, to review a lot of the anatomy from your lab portion to make sure you understand all that. Blood supply to and from the lungs, a reminder that the pulmonary circulation conducts blood to and from the gas exchange surfaces of the lungs, and the bronchial circulation is a component of the systemic circulation that delivers blood directly to and from the bronchi and the bronchioles. So you can see here the bronchial artery coming down, and the pulmonary arteries next to the air passages, and the pulmonary veins in the septum. The Mechanism of breathing. Inhalation is also called inspiration, where air is pulled into the lungs. Exhalation is also called expiration, where air is pushed out of the lungs. These two actions will deliver oxygen to the alveoli and remove carbon dioxide. And the continuous cycle of inhalation and exhalation are known as breathing. And the average amount of respirations per minute is about 10 to 15. So pulmonary ventilation, also known as breathing, is just the movement of air into and out of the respiratory system. The movement of gases follows what we call Boyle's law, where during inhalation, the volume of the thoracic cavity increases, decreasing the intrapulmonary pressure, and air will flow into the lungs. And during exhalation, the opposite will occur. Here's a look at how the thoracic cavity changes with breathing. So how during inhalation, the thoracic cavity increases in size. You can see here the vertical change as well as the horizontal change in the lungs. And during exhalation, the thoracic cavity decreases in size. You can see the vertical change and how the diaphragm will relax, kind of making itself to a cone shaped back into the upper part of the thoracic cavity. Breathing, reviewing your atmospheric pressure numbers from class. This is just a reminder that when the diaphragm moves down, the volume of the thoracic cavity increases and the air pressure inside it decreases. Breathing is reliant on atmospheric pressure, which is the pressure exerted by the air surrounding the body. Air will flow into the lungs down its pressure gradient until the intrapleural pressure will be equal to the atmospheric pressure. You can see this here. Breathing, inhaling increases the lungs, and exhaling, the diaphragm will push up, decreasing the lung space. When the diaphragm relaxes, it returns to its normal curved position, and this action will allow the volume of the air in your thoracic cavity to decrease. And as the volume decreases, the pressure in the thoracic cavity will increase. This increase in pressure is what causes your lungs to decrease in size, and this will then lead to the air inside the lungs to be pushed out or exhaled. There are many skeletal muscles associated with breathing. We often think of the diaphragm as the most important, but you have other skeletal muscles around your thoracic cage that help. Muscles of forced inhalation that pull upward and outward to help with forced inhalation are the sternocleidomastoid, your scalenes, the serratus posterior, superior, your pectoralis minor, and the erector spinae muscles. Muscles of forced exhalation, which will pull downward and inward. You have the transversus thoracis, the serratus posterior inferior, your internal intercostals, your external oblique, and your transversus abdominis. And muscles of quiet breathing that increase the dimensions of the thoracic cavity are your diaphragm and your external intercostal muscles. Regulating breathing, your nervous system will not let you have complete control of your breathing. Breathing is an involuntary action under control of the medulla oblongata in the lower part of your brain. And although you can consciously control breathing to a limited extent, such as holding your breath, it cannot be consciously suppressed. The need to supply oxygen to our cells and remove carbon dioxide is extremely powerful, and you can only hold your breath until you lose consciousness, and then your brain will take control and normal breathing will resume. Non-neural factors influencing respiratory rate and depth, physical factors, increased body temperature, exercise, talking, coughing, volation, conscious control, emotional factors such as fear, anger, and excitement are all non-neural factors that can also influence the respiratory rate and depth. Here's a look at the ventilation or breathing control by the respiratory centers of the brain. And you can see them here in the medulla oblongata. So your medullary respiratory center contains two groups of nuclei, the ventral respiratory group and the dorsal respiratory group. Each group will have upper motor neurons that extend to the spinal cord, where they control lower motor neurons of different muscles. The pontine respiratory center will modify activity of the medullary nuclei, and this will provide for a smooth transition between inhalation as well as exhalation. Carbon dioxide and hydrogen ions are the primary stimuli that cause us to breathe. The nervous system has a way to detect the amount of carbon dioxide and hydrogen in the blood. And if either carbon dioxide or hydrogen levels are too high, the nervous system will signal the respiratory center and the breathing rate will increase to try to exhale excess CO2 levels. Factors influencing respiratory rate and depth. There's chemical factors, your CO2 levels. The body's need to rid itself of CO2 is the most important stimulus for breathing. Increased levels of CO2 will increase carbonic acid, which will lead to increased hydrogen ion levels and bicarbonate ion levels. This basically makes your blood more acidic with a lower pH, so changes in your carbon dioxide will act directly on the medulla oblongata to try to decrease more CO2, so exhaling more. Oxygen levels is another chemical factor, so changes in oxygen are also detected by chemoreceptors in the aorta and the common carotid artery. Information is sent to the medulla to help control these respiratory responses. Peripheral chemoreceptors are located in the wall of the aorta, also in the wall of your common carotid arteries, and these can sense changes in the pressure of oxygen, hydrogen ions, and the pressure of carbon dioxide in the blood. They'll send sensory information to the medulla to see if the pH of the blood is too high or too low. The central chemoreceptors are located in or near your medulla oblongata. They will sense changes in hydrogen ions, which will lead us to understand the acidity levels of the blood. Increased CO2 levels in the cerebral spinal fluid will lower the pH due to increased hydrogen ions, as mentioned previously. And this is responsible for 70 to 80% of increased ventilation in response to increase of CO2 in the blood. So effects of pH on respiration. Too much carbon dioxide in your blood causes the blood to have a low or acidic pH. The pH of cerebral spinal fluid is the most powerful respiratory stimulus. It will send a signal to your respiratory center in the medulla to try to stimulate an increase in respiratory rate to try to rid the body of the excess CO2 levels. Too little CO2 in the blood will cause the blood to have a high or basic pH. This will suppress respiration and decrease respiratory rate. So what is in red here, I want you to have a good understanding. So if you have too much carbon dioxide in your blood, you'll have a very acidic pH and you will breathe more. So you'll almost hyperventilate to try to rid the body of excess CO2. If you have too little CO2 in the blood, this will cause your blood to have a high pH. So you'll breathe more shallowly or slower to try to suppress respiration. The pathology of some respiratory systems, so the most causes of lung disease are due to some type of obstruction or destruction of your respiratory pathway. This will usually lead to a difficulty in getting enough air and oxygen to the lung tissue and the rest of the body. Chronic bronchitis, asthma, and emphysema are all examples of these chronic obstructive pulmonary disorders. Asthma is an inflammation whether by mucus secretion and bronchoconstriction. It can be caused by allergies, exercise, breathing cold air. You'll get increased eosinophil and basophil activity that will increase inflammatory responses in your bronchioles. It's often treated with an inhaler, which will stimulate your smooth muscle to dilate your bronchioles, and sometimes steroids, which will decrease inflammation. Medications like Singulair for a long-term alleviation of symptoms. And this is a look at asthma. They have a nice inhaler there, and how an inflamed lung, how the swelling and mucus can block the bronchioles, but how an inhaler will try to dilate those bronchioles. Chronic obstructive pulmonary disease. This is chronic inflammation with the narrowing of airways and destruction of alveolar walls. Emphysema is abnormal enlargement and destruction of alveoli. A decrease in number of alveoli decreases the surface area and causes the bronchioles to collapse. 90% of people with COPD are or have been smokers. This will release macrophages, neutrophils, and T lymphocytes, which just destroy lung tissue over time. And increased pulmonary hypertension will cause hypertrophy and eventual failure of the right ventricle of your heart. So COPD, chronic obstructive pulmonary disorder, it's can be combined with heart issues, obesity, kind of adding it all in there. Thanks for listening, guys, and we'll see you for the next lecture.